Dear students and colleagues, hepatic encephalopathy is a reversible brain dysfunction caused by the liver insufficiency and/or portosystemic shunt, and characterized as a broad-spectrum neuropsychiatric manifestation ranging in severity from subclinical alteration to coma. The pathophysiology of hepatic encephalopathy is not completely understood, but there are exactly three critical factors for hepatic encephalopathy: is hyperammonemia, systemic inflammation, and oxidative stress by glutaminase gene alteration. And here schematically you can visualize mechanism of hepatic encephalopathy. First of all, ammonia is primarily produced in the gut by protein digestion and bacterial urease activity. The second step is alteration in the intestinal barrier cause bacterial translocation, which leads to cytokine production and systemic inflammation. The third step is the liver regulates ammonia concentration through the urea cycle, which transform ammonia into urea, which after should be excreted by the kidney in urine. And when its capacity of liver is exceeded, hyperammonemia occurs. The fourth stage is ammonia can cross the blood-brain barrier, where the only cells that are able to metabolize it are astrocytes using glutamyl synthetase, which transforms ammonia into glutamine. And glutamine acts as a osmolyte, causing neuronal and astrocyte swelling, leading to brain edema and alteration in brain metabolism. The fifth stage is a phosphate-activated glutaminase, which is located in the intestine, liver, and brain. And this enzyme catalyzes the hydrolysis of glutamine into ammonia in patients with cirrhosis, and intestinal concentration of this enzyme are higher in patients with liver disease. That's why very important that in patient who has a liver disease and liver cirrhosis especially, the function of liver decrease and convertation of ammonia decrease, level of ammonia which attack brain barrier increase, and patient has a symptom of encephalopathy. If we decrease production of ammonia by bacteria in intestine, we decrease concentration of ammonia in systemic circulation, and patient has less level of hepatic encephalopathy. It means that we can regulate grade of hepatic encephalopathy in patient with liver cirrhosis by diet and by drugs. Hepatic encephalopathy can be classified based on such factors like underlying cause, severity of disease manifestation. I will talk about West Haven criteria, classified according to time course and precipitating factors. Precipitating factors in hepatic encephalopathy includes infections, which can be followed by a previous history of overt hepatic encephalopathy. It's sarcopenia, hyponatremia, type 2 diabetes mellitus, renal impairment and acute renal kidney disease, decrease of albumin level, and some drugs like diuretics, proton pump inhibitors, beta blockers, statins, they are precipitating factor of hepatic encephalopathy. It means that massive diuresis can provocate and can lead to progression in hepatic encephalopathy in liver cirrhosis patient. Here you can see West Haven criteria of hepatic encephalopathy, and the underlying causes can be acute liver failure, it can be portal systemic bypass, it can be very common liver cirrhosis and acute on chronic liver failure. The next is severity of disease manifestation, classified into covert, its alteration to executive function, and overt manifestation range from lethargy or apathy to coma. And it can be minimal hepatic encephalopathy with no clinical manifestation, and we established by psychometric or neuropsychological test for patient. I will talk about later. The first stage hepatic encephalopathy includes cognitive and or behavior deterioration. The second stage includes asterixis, inappropriate behavior and disorientation patient. The third stage somnolence, gross disorientation, and fourth stage hepatic encephalopathy is a hepatic coma. Time course of hepatic encephalopathy classified into episodic, when hepatic encephalopathy bouts that occur at an interval more than 6 months. It can be recurrent of interval less than 6 months, and persistent when behavior alterations present always and alternated with relapses of overt hepatic encephalopathy. And we classified according to precipitating factors, non-precipitated and precipitated. Diagnostic test for minimal and covert hepatic encephalopathy when patient has no clear clinical manifestation. We use psychometric test. It includes paper pencil test. When patient do psychometric hepatic encephalopathy score, 5 tests that evaluate cognitive and psychomotor processing speed and visomotor coordination. Continuous reaction test, when registration of motor reaction time to press a button to auditory stimuli, and it measures the stability of the reaction time. But again, you can see that total cutoff value less than -4, sensitivity test is 96%, specificity 100%, very informative. We have computerized test. It's an inhibitory control test, encephal F-stroop and scan test for patient with the covert encephalopathy, and neurophysiological test, critical flicker frequency. It's a frequency at which a fused light appears to be flickering to the observer, and electroencephalography. It's one of the neurophysiological tests for covert and minimal encephalopathy. Here is example of test, psychometric test, paper pencil test from patient with liver cirrhosis. Patient for time should connect all 25 circles which present at this list of paper, and the result in normal when patient has no encephalopathy should be less than 40 seconds. If the result is 30 up to 60 seconds is latent, is a covert encephalopathy, and if patient has result more than 61 seconds is a different grade hepatic encephalopathy, but we take into account another symptom and clinical symptom, neurological symptom in patient for diagnosing. This example of asterixis, which is a neurological symptom which present in overt encephalopathy, and it's clear that patient with liver disease has encephalopathy. Diagnosis of hepatic encephalopathy means that minimal hepatic encephalopathy has no clinical symptoms, just neurophysiological psychometric test, but overt hepatic encephalopathy has symptoms and they grade of according to severity and consist of stages 2 up to 4, as mentioned above. Hepatic encephalopathy diagnosing. We can do lab tests like measuring ammonia level, but serum ammonia levels don't reflect the rate of ammonia enter into the brain. We can use imaging tests like MRI of brain. In pathogenesis, I explained that patient in hepatic encephalopathy has a swelling of brain, swelling astrocytes, and this imaging can demonstrate structural and functional cellular damage, but it has no very high level of specificity, because in another neurological disease it can be present. We can use diffusion weight magnetic resonance, which demonstrate interstitial edema in patient with minimal or overt hepatic encephalopathy. We can use positron emission tomography with fluorodeoxyglucose and demonstrate a reduction in glucose metabolism in patient with hepatic encephalopathy. Hepatic encephalopathy we can diagnose with electroencephalogram. It's a simple screening test, and patient has different patterns like rhythmic background activities. It can be transient symptoms. In patient with moderate to severe hepatic encephalopathy, we can see 3 phasic waves in ECG, electroencephalography, and you can see here example. From left you see normal electroencephalography waves, and in right side is a change of electroencephalography in patient with hepatic encephalopathy. About management such patient, we should improve mental status patient. We should identify and treat precipitating factor, because they are very important for progression hepatic encephalopathy, for triggering hepatic encephalopathy, and we should reduce duration and limit consequences of hepatic encephalopathy. After one episode of overt hepatic encephalopathy, we should prevent future episode, future recurrence, hospital admission, and we should think about quality of life patient and limiting the impact of patient's family quality of life. What's the strategy of treatment patient with a hepatic encephalopathy? Is the main goal is reduce ammonia production and or increase elimination of ammonia. Of course, attention should be focused for elimination and avoiding of precipitating factors. How we can reduce ammonia production? First of all, first-line treatment is disaccharides like lactulose and lactylol. It's non-digestible substances. When they reach the colon, they are degraded into short-chain organic acids. And the acidic environment reduces ammoniagenic bacteria and inhibits bacterial ammonia production and reduce ammonia absorption by converting ammonia to non-absorbable ammonium. That's why first line treatment with lactulose in high dose, 30-40 milliliter, it's very important for patient with liver cirrhosis and hepatic encephalopathy. The second line treatment is non-absorbing antibiotics, which reduce number of ammonia producing bacteria in intestine. It's rifaximin, which attack gram-positive bacteria, gram-negative bacteria, aerobic, anaerobic bacteria, and we use for treatment hepatic encephalopathy. Plus, patient need L-ornithine L-aspartate, LOLA, which reduce blood ammonia level by providing substrate to stimulation urea and glutamyl cycle, and result is a conversion of ammonia into urea and glutamine. And albumin, which is necessary for patient with liver disease, with liver cirrhosis, and has many positive properties, is a modulating anti-inflammatory response, detoxification, and has a many positive effect for hepatic encephalopathy progression. Dietary management should include intake of calorie 35 up to 40 kilocalorie per kg per day for patient, and use 1.2 up to 1.5 gram per kg protein daily, regardless of the present hepatic encephalopathy. And necessary to note that vegetable protein are better tolerated for patient with hepatic encephalopathy. And one of the methods treatment patient with liver cirrhosis with hepatic encephalopathy is FMT, fecal microbiota transplantation, which improved neurocognitive test, decrease readmission rate, and improve quality of life and life expectancy in patient with liver cirrhosis. Thank you for attention.